Well, I've been asked to speak about sustainable health education and the COVID-19 pandemic. But before I do that, can I congratulate you all on setting up this wonderful new centre, which I'm absolutely delighted to be having a part in. As I understand it, your vision for sustainable health education is that your students will develop a global vision. They will develop systems thinking, a commitment to social justice, critical engagement with the evidence-based, not just being evidence-based, but questioning what we mean by that evidence-based, and an interdisciplinary, interprofessional, and collaborative approach to learning. Now, since I was asked to talk about the pandemic, I thought I'd distinguish between two kinds of science, easy science and what I've called difficult science. So an example of easy science, dexamethasone for severely ill patients with COVID-19. In this example, randomized controlled trials were relatively easy to do. They quickly produced definitive evidence, which was distributed around the world and literally changed practice overnight. Difficult science, masks and face coverings for preventing the spread of COVID-19. And here's a picture of President Trump refusing to take the mask that he's been offered. There were no randomized controlled trials, at least not on COVID-19, and arguably such trials were impossible because, of course, the mask is mainly for source control. But we'll all agree that masking quickly became a political issue, and scientists took sides, or they were depicted as taking sides. Now, a standard definition of evidence-based medicine, well, my definition is nice, clean experiments on well-defined population samples. And the dexamethasone example is a good example of that. You've probably seen this hierarchy of evidence with the randomized controlled trials, the systematic reviews at the top, and then down through the rainbow, these other kinds of evidence which are defined in this hierarchy as less good, less worthy. Now that's fine. In relation to dexamethasone, I'm absolutely in support of this hierarchy, but it doesn't work so well when you apply it to masks. This is a screenshot from the Centre for Evidence-Based Medicine at the University of Oxford. So the same university as me, but this is a different research centre. And it's run by Carl Hennigan, and his colleague Tom Jefferson worked with him to do some systematic reviews of randomized trials in relation to masks. And you can see the conclusion they came to. Evidence from 14 trials on the use of masks versus no masks was disappointing, they say. It showed no effect in either healthcare workers or community settings. Now, what they did here to produce their review was they took the top of the triangle. They took the randomized controlled trials and all other study designs. They metaphorically, they threw them in the trash can. And I just want to question this. But first of all, I want to remind you of this wonderful paper written by Ivan and his colleagues, Tony and John. They're probably listening, actually. I hope they are. I love this paper because what they're doing is questioning the knowledge translation metaphor. And they argue that translation from one language to another is never done by what I'm calling a bilingual parrot. It's never direct. Rather, that translation involves judgments, compromises, and attention to different audiences and contexts. Similarly, they argue in this paper, the translation of research evidence is not a simple act of summarizing and handing over facts. Rather, it involves judgments and, as we've heard before, value-driven choices. And I think I want to just unpack what we mean by some of those values. What did Hennigan and Jefferson throw into the trash can? What kinds of evidence did they ignore because it was too far down the hierarchy of evidence? Many kinds of evidence. For example, these sneeze videos, pictures of people sneezing with the droplets lit up. This didn't look very scientific to them, even though it was published in the New England Journal of Medicine. And these stories of people going to choir practice and then many, many members of the choir developing COVID-19, some of whom died. Again, this wasn't a scientific experiment, so they just said we don't need to take any notice of it. And perhaps most interesting of all for the purposes of today, they ignored the stories of other countries. This is a graph from a paper by Christian Loeffler and his colleagues. Up the vertical axis is mortality, this is deaths, and along the horizontal axis, time from the first case of COVID-19 in a country. And you can see that countries that introduced masking by 15 or by 30 days had almost no deaths, whereas those who didn't had very, very high death rates. And we can argue about why that might be. But the interesting thing that I wanted to point out is this idea that this was interpreted as a cultural thing for the Asians. Oh, those Asians, they wear masks. It's what they do, like they eat strange food, this kind of thing. It was never seriously taken on board or explained within that Center for Evidence-Based Medicine. Now, back in March, some colleagues and I wrote this paper in the British Medical Journal, arguing for what we called the precautionary principle. We don't have 100% proof yet, but the evidence is pointing in the direction that masks could save many thousands, perhaps hundreds of thousands of lives. So let's err on the side of caution. Let's wear them because we don't think they can do much harm. This probably changed practice in the UK. It took a few weeks, but it wasn't very popular amongst people who were opposed to masks. So this is a message which was posted in the chat column when I gave a Zoom lecture on masks from the University of Oxford a few weeks ago. And the person who posted this was signing in with a white male name. We don't know whether it was a false name, but it sounds like this person identified as a white male. And I also have received many, many personal threats and websites. You can search my name if you want and find the websites that have been set up to attack me and discredit me as a scientist. And there's a lot of scientists working around COVID-19 who are getting this kind of treatment. Martin McKee and his colleagues published this paper, Are Populist Leaders Creating the Conditions for the Spread of COVID-19? And in this, they used political science theories and methods to present the case that the libertarian right in general are anti-masks, anti-lockdown, pro-segmentation, the idea that the old and vulnerable should stay at home in order that other people should be able to enjoy their freedom. And of course, the question of herd immunity. Let the disease sweep over the country. Yes, some people will die, but you know, they're expendable. There is also a paper which I think your students should read, actually. It's a beautiful paper by Jason Harsin called Toxic White Masculinity, Post-Truth Politics and the COVID-19 Infodemic. And what he argues is that the proponents of these views tend to be, although they are not always, white and male, aggressively confident and hierarchical, and dismissive of female traits such as emotionality. That includes caring about these deaths, and power sharing and admission of uncertainty. And I was really interested when Kristen and Ole, I think, talked about the main barrier to the SDGs might be indifference, that caring about social justice is seen as some kind of weak thing. Well, let's go to the Great Barrington Declaration. These are 3 professors, one from Oxford, one from Harvard, one from Stanford, bringing the weight of their ancient institutions behind some very extreme claims. They claim that COVID-19 isn't a very bad disease, especially if you're healthy and under 60. And again, I note that Ole was talking about health goals being subordinated to economic goals. And I think the Great Barrington Declaration is a great example of that, because what they're focusing on is the economically active population. You really don't matter once you've become old or disabled or sick. They say that the evidence base for interfering with people's lives is weak and that the economy should be prioritized over further lockdown. Now, there was a rival memorandum published, I think, in the Lancet and also on the web. I was involved in the second one called the John Snow Memorandum, and we argued that COVID-19 is serious and sometimes deadly, that all citizens count, even if they are old or sick, that the best way to serve the economy is to address public health. And I think that's probably something that most of us listening today are aligned on. And also that we all need to make compromises for the good of society. So before I stop, I've developed some techniques which have helped me to cope with the abuse that I'm getting and with the very difficult struggles that scientists, particularly public health scientists, are facing in this highly toxic current environment where science is being twisted for ideological reasons. The first technique is reflexivity. This is a picture of a place very close to my house. It's the River Thames. I sometimes go for a swim here, but I always go and spend about an hour out of doors reflecting and having some headspace before my very busy day. And I'm sure that reflexivity is going to be one of the things that you encourage and nurture in your students. Secondly, not so pleasantly, painful engagement, engaging with the abuse that you get for trying to, shall we say, speak truth to power. I need to read the abuse that I'm getting. I need to read those articles attacking my work. Thirdly, and again, I think this is something that your centre might well teach the students, is epistemological labour. Sometimes that triangle sits very nicely with the red at the top, and what we need is a randomized controlled trial. Sometimes we need to push the triangle and say, wait a minute, we need to look at other kinds of evidence, much more interdisciplinary, respecting the methods of disciplines beyond our own. And fourthly, deconstruction, close reading of the text and unpacking what the fundamental positions and assumptions and arguments are. And we really don't do enough of that in schools of medicine. So I hope that that's one of the things that you're going to be doing with your students in your new centre. Deconstructing the science of masks, for example, we could ask what counts as facts here and how do those facts become legitimate? We can look at masks as PPE, personal protective equipment, to be tested like a drug in RCTs, randomized trials. But we could also bring a more political lens to bear. We could look at the supply chain problems with PPE, which are linked to controversial choices with contracts and so on, hidden vested interests, the commercial determinants of health that Ole spoke about earlier on. I was asked to write an article for The Guardian about the Great Barrington Declaration, and I pushed back at the idea that we should be tackling them on scientific grounds. I said, we know it's bad science. We know there's no evidence for this herd immunity hypothesis. I will not write against that. What I want us to all talk about is who is funding this bad science. Where did they get their money from? And we wrote this article along with Martin McKee and Michelle Kelly-Irvin, questioning the right-wing libertarian think tanks that were funding that declaration. So here's some examples of some of the papers that I and also people in your centre have been writing around the topics of epistemological labour and deconstruction. And I very much hope you're going to be doing more of that along with the other work in your new centre. So thank you very much for your attention. Pick me up on Twitter if you want to talk and ask some questions.